My name is Dr. Michael Perelman, and here are my disclosures. I want to thank the program committee for inviting me to speak on this frequently misunderstood topic, and thanks to the AUA for their recognition of mental health professionals and their role in managing disorders of ejaculation this past summer. But most important to this Wrestlemania debate, I want to thank Dr. Alan Shindell for chairing the AUA committee, the guidelines on ejaculation, which recommended, quote, clinicians should consider referring men diagnosed with lifelong or acquired delayed orgasm to a mental health professional with expertise in sexual health. But the title of this debate should have been Sex Coaching by Any One of You should be the first-line therapy for DE, whether you're a urologist, a PA, a nurse, or a mental health clinician. You do not need to be an expert sex therapist or a skilled sex therapist to assist many men with DE. You only need to ask key questions and provide crucial suggestions to make a difference. So why is that? Overwhelmingly, DE cases you see are situational. The vast majority of DE patients are complaining about DE during intercourse and can already ejaculate with self-stimulation. So the following information will allow you to help many of these men with DE without the need for drugs and may negate the necessity of a referral to a mental health professional. So what do? A good sex history will likely expose the psychosocial and cultural reasons for DE, insufficient penile or psychological stimulation, high frequency or idiosyncratic masturbation, preference for masturbation over partnered sex, and psychological conflict regarding ejaculation. These issues often combine and overlap. But what you want to do is ask specific questions, like, tell me what you mean by DE. What do you think is causing this problem? Then you want to listen, clarify, ask some questions as follow-up depending on the time you have available. But in the end, decide to counsel yourself or refer to a professional with sex therapy expertise depending on the history's psychosocial severity. But detailed questions about masturbation will likely provide some key information. My 2005 AUA poster presentation first documented idiosyncratic masturbation and high-frequency masturbation as hidden causes of DE. As noted in the guidelines, again shared by Dr. Shindell, quote, some men report high-frequency masturbation, idiosyncratic masturbation style, discrepancy between the reality of sex with their partner and their sexual fantasies. Ejaculation frequency is often a primary cause of DE. With age, some men who are used to high masturbation frequency can no longer sustain it without losing the ability to ejaculate with their partners. Ejaculatory thresholds differ among men across situations, all described by the sexual tipping point model. And this is all illustrated and completely explained on the mapedfund.org website, our foundation's website, for those seeking greater understanding. Question the man regarding his masturbation habits, including technique and frequency, speed, pressure. Does technique change as ejaculation approaches? What's the latency time? Are lubricants being used? What is the body position? But most importantly, ask your patient what's different in your experience of self-stimulation versus partner stimulation. Specifically, what physical sensations and thoughts are different. What you're assessing for is immersion in erotic versus anti-erotic intrusive thoughts, like it's taking too long. Have they communicated any of this to their partner? How did their partner respond? Now, if you or your patient are uncomfortable with this plan, please at least recognize for yourself and tell him there's accumulating evidence indicating the role of masturbation in the etiology of DE. And understanding how he stimulates himself and how it differs from his partnered experience will help you assist him. There's a Psychology Today blog called Why Delayed Ejaculation is More Common Than Folks Realize. You can download that and share it with your patient to help you explain this. There's one caveat though, only counsel to your and your patient's comfort level. If either of you are too uncomfortable, refer to a clinician with sex therapy training, which would then be the best first-line treatment. The solution is usually decreasing ejaculatory frequency while finding ways to increase the quality of friction and erotic thought. Typically, he must temporarily suspend masturbation activity. The temporarily refraining from ejaculating alone will cause a desire for release to increase, and for the stimulation need to ejaculate with a partner to be much easier. Now, this may not suffice to solve the problem entirely for partnered sex, but it's definitely increasing the probability, and that's something you can do. What are the exceptions? Psychosocial factors will still contribute, but in cases of primary DE, the likelihood of biomedical etiology is high, in which case you want to be doing a physical exam, laboratory testing, etc. You're looking for anatomic, hormonal, neurologic, iatrogenic, and pharmaceutical factors that all have to be ruled out. I'm sure Dr. Schindel will explain this more fully. So, how to negotiate with the patient to follow this guidance? Enlisting their cooperation and other aspects of sex coaching are just too complex to describe in the few minutes that have been allotted to me. But complete guidance can be found at mapedfund.org. That offers a free download of numerous presentations and publications on this topic. So per AUA guidelines, behavioral interventions are a low-risk option that may help some men with DE enhance arousal and trigger orgasmic response. They should be your first-line therapy. Thank you for listening.